Hello, hello, hello. Good morning, ladies and gentlemen. Hello. Today we are talking about connective tissue disorders. We have just finished up with the musculoskeletal system, so now we are going a little deeper into the tissues, into the muscles and the joints, and we're going to be talking about connective tissue, which will again involve a lot of lifestyle changes. So, class outcomes for this chapter, we will summarize the pathophysiology of the more common connective tissue disorders. We will identify the diagnostic studies associated with connective tissue disorders. We will differentiate between the abnormal assessments and a quote unquote normal adult assessment. We will judge the appropriateness and safety of these medications. We will evaluate the needs of clients with connective tissue disorders and or their families for education um, in order to manage the disorder. Because again, a lot of this is going to be education based and lifestyle changes. And because we are nurses, we are going to formulate that plan of care for a client that has a connective tissue disorder. So, connective tissue is the most widely distributed and abundant tissue in the body. It is an extracellular matrix made up of ground substance, collagen, and elastic and reticular fibers. Connective tissue will provide support, structure, insulation, and cushion to tissues and organs to the body, as well as fill space. In connective tissue disease, the collagen and the elastin are typically damaged through inflammation or an immune system dysfunction. So, bone, cartilage, tendons, ligaments, lymphatic tissue, and blood are all examples of connective tissue. So, osteoarthritis, OA. It is the most common form of arthritis. It is the leading cause of chronic disability. It will involve weight-bearing joints such as the knees, hips, the feet, and the lumbar spine. All of this is not new. This is a little old. It also affects the cervical spine, proximal interphalangeal joints, and distal interphalangeal joints of the hands. Osteoarthritic involvement of the shoulders and elbows usually occurs after trauma, inflammation, or overuse. So, ladies and gentlemen, please listen up, and then listen up one more time. There are multiple risk factors, including age, the fact that we are female, obesity, occupations that involve repetitive motions. This will put someone at risk. Sports activities, a previous injury, because we know if it happens once, it's going to happen again. Muscle weakness, genetics, history of inflammatory arthritis, and other bone and joint disorders. Obesity will be the single most modifiable risk factor. Obesity will correlate most closely to the development of knee osteoarthritis. So, obesity increases stress on weight bearing joints, which also contributes to osteoarthritis. There have been links made between certain occupations and osteoarthritis. Remember those repetitive movements. So, for example, individuals whose jobs require repetitive knee bending are prone to develop knee osteoarthritis. Individuals who perform physical labor are at an increased risk for developing hand and knee osteoarthritis. So, ladies and gentlemen, listen up, and then listen up one more time. Aging is one of the most prevalent risk factors. However, osteoarthritis is not considered the normal process of aging. 80% of individuals over the age of 55 will be affected. Age will be a factor. In general, women are more commonly affected. Osteoarthritis of the hands is most prevalent. Ladies and gentlemen, please take note. Osteoarthritis is a disease that affects the joint as a whole because of biological, chemical, and viscoelastic changes within the joint. Cartilage, synovium, subchondral bone, synovial fluid, ligaments, periarticular muscle, and sensory nerves will be altered. Cartilage is a material made primarily of water, collagen, proteoglycans, and elastins. Osteophytes are projections of new cartilage and bone growth that will form along joint lines, contributing to pain in the joint and then decreased range of motion. Osteophyte formations are on the proximal interphalangeal joints, and distal interphalangeal joints are referred to as Bouchard's nodes and Herbidine's nodes, respectively. Cartilage loss is a clinical feature of osteoarthritis, causing the bone to be unprotected, which will lead to the deterioration of joint function. The synovium is a membrane that will line the non-cartilaginous surfaces of highly movable joints. And here we just have what we would call the hotspots of where osteoarthritis would form. So, in osteoarthritis, the synovial membrane may become thickened and overproduce synovial fluid, causing more pain and even greater restriction on joint movement. Chronic effusions and overproduction of synovial fluid may cause collateral ligaments to stretch, leading to joint laxity or looseness and mechanical instability, compounding joint damage. So, some clinical manifestations will include progressive pain over time, decreased range of motion, tenderness to touch over the joint line or around the joint, bony swelling, soft tissue swelling, a deformity, and instability. Crepitus. Crepitus is a crackling, grating sound or feeling due to air or gas under the skin, and this may also be present. Patients typically experience more pain with activity, which will improve with rest. So, diagnosis is made based on clinical manifestations without laboratory testing or radiographs when the patient is 45 or older and presents with persistent usage related pain in several joints and morning stiffness that will last less than 30 minutes. So, the American College of Rheumatology developed criteria for the diagnosis of osteoarthritis of the hand, hip, and knee initially way back in 1986. However, this criteria is still current today. We still use this criteria. Laboratory testing may be performed to rule out other diagnoses, such as rheumatoid arthritis, and laboratory testing should be conducted as a part of the medical management of osteoarthritis in order to monitor for side effects that may be related to medication use. Plain radiographs of the affected joints, such as the hands, the hips, the knees, and the spine, along with a history and physical examination, can be used to confirm the diagnosis. So evidence of osteoarthritis may not be seen until the disease is well advanced. Hmm. So treatment will be both pharmacological and non-pharmacological. There is no therapy available to stop progression of the disease. So the goal of care will be to include decreasing pain and improving or maintaining joint mobility while avoiding the toxic effects of pharmacological therapy. So, non pharmacological therapies will include the following: weight loss, if that is indicated, heat and cold compress applications, aerobic exercise, physical therapy, including range of motion and muscle strengthening exercises, the use of ambulatory assistive devices, and then appropriate footwear. And this may include lateral wedged insoles. Occupational therapy can be employed, joint protection. We will talk to them about energy conservation and educate them on assistive devices for activities of daily living. So, pharmacological therapy will include acetaminophen, otherwise known as Tylenol, which can be used in patients with mild to moderate pain. Patients with more severe pain will be treated with NSAIDs, non non-steroidal anti-inflammatory drugs. Pain not managed with acetaminophen and NSAIDs may warrant treatment by using intra-articular injections of a corticosteroid. Opioid analgesics are an option but should be used sparingly because they may become habit forming. Surgical interventions may be necessary for some patients suffering from disability and severe pain, and these procedures will include arthroscopic irrigation and or a debridement, arthroscopic synovectomy, a surgical fusion, or a total joint replacement. So, nursing management of osteoarthritis. The nurse may identify the following: an unsteady gait, bony enlargement or swelling of the affected joint, fatigue, painful range of motion of the affected joint, an elevated serum creatinine level secondary to NSAID use, elevated liver enzymes related to multiple medication use, constipation secondary to decreased physical activity and or the use of narcotic analgesics. Some nursing diagnoses for osteoarthritis: pain related to the disease process, ineffective sleep patterns related to the pain, and a self care deficit related to decreased range of motion. So, some nursing interventions for osteoarthritis. We are going to assess. We are nurses, and that is what we do. We are going to start with vital signs. Hypertension may occur related to chronic NSAID therapy that will alter the renal function, reducing sodium excretion and increasing fluid retention. And we will assess their weight. The use of NSAIDs may alter renal function, leading to weight gain. Skin integrity. Skin breakdown may occur in bony prominences due to decreased mobility. We're going to look at the serum creatinine. The use of NSAIDs may lead to renal impairment by blocking essential prostaglandins, which will maintain blood flow to the kidneys, causing an increase in the serum creatinine level. Some nursing actions for osteoarthritis. We are going to administer analgesic and anti-inflammatory medications as doctor orders. We can provide cold packs for painful joints. Cold will reduce the inflammation in the joint. We can provide heat for painful muscles. Heat will relax the muscle and cause vasodilation, which will improve blood flow and then promote healing of that muscle. So, some patient education, osteoarthritis. We will educate the patient to take medications only as prescribed. Misuse or overuse of analgesics and anti inflammatories may lead to side effects and can be dangerous. NSAID therapy may increase the risk of myocardial infarction, otherwise known as an MI, GI bleeding, stomach ulcer, renal insufficiency, and abnormal platelet function. We will educate them to report chest pain, abdominal pain, abnormal bleeding, and blood in the stool or emesis if they begin vomiting blood. This may all be signs of NSAID toxicity or an indication for an MI. We will educate them to participate in regular physical activity. We will educate them to assist with referring the patient to occupational and physical therapies. We will assist with referring the patient to an orthopedic surgeon when necessary. Surgery may be necessary for end-stage osteoarthritis once other treatments have failed. And we can also assist with a home healthcare referral. And then how do I know? How do I know that I've done a good job caring for this patient with osteoarthritis? It will be important for patients to maintain their function, and the patient will have their pain under control and have good unrestricted movement. So, moving on to rheumatoid arthritis. Females will be 3 times more likely to be affected than males. Rheumatoid arthritis can occur at any age, but it is most common in the third through the fifth decade. Incidence will increase after the sixth decade, and why this happens is unclear. So it is well understood that genetics and environmental factors will play a key role in the development of rheumatoid arthritis. First degree relatives are at a 1.5 higher risk than the general population. Environmental factors such as cigarette smoking, bacteria, and viruses have been implicated as initiating factors in the genetically predisposed population. So, some patients initially diagnosed may experience long term remission within 1 year of onset. However, for those patients who do not enter remission, about 60% will be disabled within 10 years. So, rheumatoid arthritis is a chronic systemic autoimmune inflammatory disease. It is characterized by an inflammatory process that will affect diarthroidal or freely moving joints, causing pain and swelling. This will primarily target the synovial membrane. The synovial membrane will become thickened and promote the destruction of the joint. So, some clinical manifestations of rheumatoid arthritis will include joint pain, joint swelling, erythema, morning stiffness, and fatigue. Onset is often insidious meaning gradual and subtle. So, onset will be gradual with vague complaints of joint and muscle pain that will evolve into joint pain with synovitis. And synovitis is inflammation of the synovial membrane, and this can lead to joint destruction and deformity. So, if left untreated or inadequately treated, this will lead to irreversible joint damage and disability. So, ladies and gentlemen, listen up, and then listen up one more time. Common joint deformities will include swan neck deformity caused by hyperextension of the proximal interphalangeal joints, a boot and ear deformity caused by abnormal flexion of the proximal interphalangeal joints, and then ulnar deviation, and this is caused by the lateral deviation of the phalanges. Ladies and gentlemen, please take note. So, clinical manifestations of rheumatoid arthritis. Rheumatoid nodules may be formed in subcutaneous tissue over the bony prominences. So extra articular meaning outside of the joint. And this will include osteopenia, which, if we remember, is decreased bone density, muscle weakness, episcleritis. Episcleritis is red, painful inflammation of the episclera without a discharge. Sclerotis, scleritis. Scleritis is inflammation of the sclera, which will produce deep ocular pain. Pleuritis is an inflammation of the lining surrounding the lungs. Pleural effusion, and this is excess fluid accumulation around the lungs. Pericarditis, and this is inflammation of the fibrous lining that will surround the heart. They may have an enlarged spleen, and we may note anemia. So, diagnosis will come by combining clinical manifestations, laboratory values, and radiographs or ultrasound. The American College of Rheumatology and the European League Against Rheumatism have worked together to update their criteria for diagnosing the disease at an earlier age. So patients will typically present with peripheral joint pain, usually symmetrical, and complain of morning stiffness that is lasting greater than 30 minutes. Symptoms will present 6 weeks or longer, and this will be consistent with RA. And then another important finding will be the synovitis. So, laboratory testing for rheumatoid arthritis is not conclusive, but it will be done to help with diagnosis and to monitor for side effects when we start medications. So, the presence of antibodies, rheumatoid factor, and anticyclic citronellide peptides may assist in the confirmation of the diagnosis. But the absence of these does not exclude the diagnosis because approximately 20 to 30% of patients will be negative for these antibodies. So doctor will just use this just as a guiding factor. Also, a positive rheumatoid factor does not always indicate the presence of RA. So, acute phase reactants, such as a C-reactive protein, CRP, and erythrocyte sedimentation rate, which would be an ESR, these may be used to detect inflammation. However, these are not specific for RA. So an elevated CRP and or an ESR will be an indicator that can be useful in distinguishing inflammatory from non-inflammatory arthritis. So obtaining information regarding renal and hepatic function is necessary before initiating therapy because many medications used to treat RA will be toxic to the kidneys and the liver. So baseline complete blood counts are necessary because anti-rheumatic medications may cause cytopenia. Cytopenia is a reduced number of blood cells. So before the initiation of most biological therapies, an option for treatment of RA, we will do a tuberculin skin test and hepatitis testing to determine whether or not we can use biological therapies um, for RA. So conventional radiographs are used to assess for bony erosions and joint space narrowing. These may be repeated during treatment to assess for disease progression and efficacy of pharmacological therapy. So, an MRI may detect erosions that are not detected by conventional radiographs. Ultrasonography may also be used to assess for synovitis and erosions that are not detectable by plain radiographs and is a good option for patients who will decline an MRI because of the cost or they may be claustrophobic. So, treatment of rheumatoid arthritis. Um, Non-pharmacological therapy. Education is very important in the management of RA. Patients must understand their disease and the measures they can take to help manage the disease. So, range of motion exercise will promote joint mobility, reduce that stiffness, and improve muscle strength. And then aerobic exercise will promote cardiac health. Physical and occupational therapies may be necessary to teach patients appropriate exercises, how to protect their joints, evaluate the need for assistive devices, and then proper use of the devices. So, proper nutrition is important to maintain good health, prevent obesity, and decrease the risk of heart disease. And it is important for patients to take rest periods to manage fatigue and joint pain. So, pharmacological therapy for RA, the goal will be to control the inflammation that will lead to joint and tissue destruction, decreasing joint pain, synovitis, and stiffness, as well as maintaining joint function and then preventing that joint destruction. Treatment decisions are based on disease severity and response to medications. Initial treatments will include analgesics, NSAIDs, and then glucocorticosteroids. So, glucocorticoids, such as prednisone, may be given orally, intramuscularly, intraarticularly, or IV, and they can suppress inflammation and then alter the disease process. But these are not safe at high doses over a very long period of time. So patients whose disease does not respond very well to a combination of analgesics, anti-inflammatories, and low-dose prednisone will be treated with disease-modifying anti-rheumatic drugs, otherwise known as DMARDs. Synthetic DMARDs will include, but are not limited to, methotrexate, Arava, Plaquenil, Azolfadine, and Xeljanz. So before starting DBARD medications, patients should inform their healthcare provider of a history of or exposure to an anti-tuberculosis. Many patients will respond well to methotrexate, which has been accepted as the first line DMARD of choice. Traditionally, patients will move on to additional or alternative medications if methotrexate alone does not control the disease. So, over the last decade, several medications known as biologics. Biologics are genetically engineered medications made from living organisms and their products, such as proteins, and these medications have obtained approval by the United States Food and Drug Administration to treat RA. These medications have proven to be beneficial in slowing or even halting the progression of RA. The approved biological therapies must be given IV or they can be injected subcutaneously. So, surgical management of RA. Surgical intervention, including joint replacement or a fusion, may be necessary to help alleviate pain, but may not actually improve function. Patients who choose to have surgical removal of rheumatoid nodules, but they have to know that these nodules may return over time. So, complications of rheumatoid arthritis may be caused by uncontrolled disease or as a result of pharmacological therapy. Extra-articular complications will include increased risk of infection and increased risk of developing a cancer. So, nursing management of rheumatoid arthritis. Clinical manifestations are related to pain and decreased function of the affected joint. There may be clinical manifestations related to pharmacological therapy. So, the nurse may identify the following: an unsteady gait, bony enlargement or swelling of the affected joint, warmth and redness of the joint, painful range of motion of the affected joint, increased incidence of infection, and elevated serum creatinine secondary to NSAID use, elevated liver enzymes secondary to methotrexate, constipation that is secondary to decreased physical activity and or the use of narcotics, nausea and oral ulcers that will be related to methotrexate use, a cough and or shortness of breath due to interstitial lung disease, which can be caused either by RA or methotrexate therapy, a self-care deficit, and fatigue. So some nursing diagnoses for RA, pain related to the disease process, ineffective sleep pattern related to the pain, and then a self-care deficit related to decreased range of motion. So some nursing interventions for rheumatoid arthritis. We are nurses, so we are going to assess. We are going to look at their joint pain and mobility, indicators for efficacy and disease progression. Do they have a temperature? An increased in temperature is an indicator of infection. We can look at their labs, laboratory testing, CRP and ESR related values will be indicators of inflammation. Hemoglobin. Hemoglobin may be less than normal in patients with active RA, but a decreased value may also indicate a GI bleed, which can be caused by the NSAID use. Serum albumin. This can be a decreased value with increased disease severity because it is a negative acute phase reactant and decrease in response to acute inflammation. Platelet count may be elevated in very active disease because inflammation will cause an elevated platelet count. So liver and renal function, elevated levels may be due to medications used to treat RA. And we can assess for a pleural effusion, pericarditis, scleritic, scleritis, episcleritis, and osteopenia. Extra-articular clinical manifestations of RA may be present due to the inflammatory changes outside of the joint. So, some nursing actions for rheumatoid arthritis. Ladies and gentlemen, listen up, and then listen up one more time. We are going to administer analgesics and anti-inflammatories as doctor has ordered. We will administer glucocorticoids as doctor has ordered. This steroid therapy should be a tapered dose treatment plan. And these medications should be taken at the same time every day. We could administer DMARD therapy as ordered, and we could administer biologics as they are ordered. Ladies and gentlemen, please listen up, and then listen up one more time. Patient education for rheumatoid arthritis. We will educate the patient on the importance of adhering to the treatment plan. They need to know to report signs and symptoms of infection because immunosuppressive therapy should be discontinued while patients have an active infection. Immunosuppressive therapy will put patients at a higher risk of developing an infection and then a complication from that infection. So, ladies and gentlemen, please take note. We will assist with referral to an infectious disease specialist for patients with chronic or atypical infections. So, patients with rheumatoid arthritis who are on immunosuppressive therapy are at risk for developing an infection. They need to keep current with vaccinations. However, patients should not receive live vaccines if they are on immunosuppressive therapy. We can help to refer to physical and occupational therapies as needed. And then how do I know that I've done a good job taking care of this patient with RA? Important assessments of the efficacy of pharmacological therapy are the amount of joint tenderness, and synovitis the patient is experiencing, as well as the duration of their morning stiffness. Teaching the importance of using anti-rheumatic medications properly and consistently will be key in treating this population. So ideally, the patient with well-controlled RA will have very few or no tender or swollen joints with minimal morning stiffness while experiencing little or no adverse effects from pharmacological therapy. So, moving on to lupus. Systemic lupus erythematosus, otherwise known as SLE, will affect fewer than 25 people per 100,000. Prevalence rates will vary depending on gender, ethnicity, geographic location, and age. So the female to male ratio in children will be 3 to 1, but it can be as high as 5 to 1 for women during childbearing years. And 65% of patients are diagnosed between the ages of 16 and 55. Less educated patients and those with low socioeconomic status are likely to have poor disease control. Men are more likely than women to have renal disease, skin manifestations, laboratory abnormalities, neurological involvement, thrombosis, cardiovascular disease, and vasculitis. So women are more likely to suffer from Raynaud's phenomenon, photosensitivity, and mucosal ulceration. So people who have relatives with SLE are at a higher risk for developing the disease. There have been genes that have been identified that will predispose humans to SLE. So, systemic lupus erythematosus is a chronic inflammatory disease that can affect virtually any organ system. Etiology is unknown, it is unclear. The disease can be triggered by multiple factors, and these factors will include pregnancy, exposure to sunlight, another illness, major surgery, cilia dust, medication allergies. So, most clinical manifestations of SLE will be attributed to antibodies and the creation of immune complexes that will be deposited into tissues. So, clinical manifestations of lupus are diverse. They will not follow a clinical pattern and they can vary greatly from person to person. So, the clinical course usually involves periods of remission and then acute disease flares. And then clinical manifestations will vary according to the organ system. So, diagnosis is going to be complicated and frustrating for the patient because there is no specific test to diagnose SLE. Laboratory findings are used to support or confirm the diagnosis when combined with the patient history and then the physical examination. The ACR has developed guidelines to help in the diagnosis, and the Systemic Lupus International Collaborating Clinics has revised and validated the classification criteria to help in diagnosing. So they have identified 17 broad criteria that will align with the clinical manifestations with specific definitions. Some are clinical, some are immunological. The clinical criteria will include, ladies and gentlemen, please take note, skin rashes such as the lupus malar rash. And this is the hallmark sign of the butterfly rash over the bridge of the nose and the cheeks. This is a hallmark sign for lupus. Oral ulcers, thinning hair, joint tenderness, pleural or pericardial effusions, renal and neurological disorders such as seizures, confusion, and there may be protein in the urine. Hematological disorders such as thrombocytopenia, leukopenia, or anemia, Now, the immunological criteria can include a positive anti-nuclear antibody, otherwise known as an ANA, a low complement, a positive anti-SM, anti-phospholipid antibodies, a positive anti-double-stranded DNA. So, 4 of the 17 criteria must be present in order to support a diagnosis, or the patient needs to have 1 clinical and 1 immunological. So, in clinical practice, patients may not have 4 criteria present to be diagnosed if there is sufficient evidence otherwise. So, laboratory testing will be used to confirm some of the clinical and immunological criteria. So, first, testing is done to confirm the presence of the autoantibodies. Patients with SLE will produce anti-nuclear antibody, INA, confirming the existence of an autoimmune disease. So the presence of an ANA does not itself confirm the diagnosis, as approximately 2% of healthy individuals are also going to test positive. Anti-DNA and anti-SM antibodies are more specific for SLE because these autoantibodies are rarely found in other conditions. So antiphospholipid antibodies should also be assessed because the presence of these antibodies may lead to formation of a blood clot. Laboratory values to evaluate the clinical criteria include a complete blood count, a CBC, to check for leukopenia. Leukopenia is decreased white blood cells. Thrombocytopenia. Thrombocytopenia is a decreased platelet count. And then anemia. Anemia is decreased red blood cells. So urinalysis with random protein and creatinine, along with serum creatinine and a BUN, should be evaluated and monitored closely in order to detect a kidney disease early in the going. C-reactive proteins and ESR, again, are markers used to identify inflammation, but these will not be specific for SLE. C-reactive protein and ESR may be monitored to assess for level of disease activity and then response to treatment. Radiographical imaging is beneficial to detect or assess some of the clinical criteria or to eliminate other causes of symptoms. So, treatment of lupus. Non pharmacological interventions include avoiding prolonged sun exposure and then using a sunscreen, SPF higher or daily. A well balanced diet is recommended for proper nutrition, frequent rest periods, and a regular sleep schedule to help combat fatigue. And then regular exercise will improve strength and maintain range of motion, as well as a healthy weight. Pharmacological therapy for lupus, pharmacological interventions for patients are typically based on disease manifestations. Anti-malarial medications such as Plaquenil are frequently used to treat patients. So the most common side effects related to Plaquenil use are abdominal pain and nausea, which may improve over time. Non-steroidal anti-inflammatory medications such as ibuprofen are used in treating arthralgias, myalgias, headaches, and fever. So, glucocorticoids may be necessary to suppress inflammation in joints, kidneys, and other organ systems. Immunosuppressive agents such as methotrexate may be necessary to treat joint inflammation, which does not respond to NSAIDs or steroids. Ladies and gentlemen, please listen up, and then listen up one more time. Methotrexate is a cytotoxic medication. So, the patient needs to be educated to avoid pregnancy as this medication can cause a birth defect. Benlysta is a biological response modifier that has been approved in 2011 for treatment, and it is the first new treatment to be approved in more than 40 years. Ladies and gentlemen, please take note. Surgical management may include renal transplant for patients with severe lupus nephritis and joint replacement for patients at risk for avascular necrosis of a large joint. So, some complications of lupus will include renal failure, premature heart disease, interstitial lung disease, hypercoagulation, stroke, avascular necrosis of the joint, increased risk for infection, and complications may also arise from toxicities related to pharmacological therapy. Nursing management of lupus. There are many clinical manifestations that the nurse may identify, including fatigue, difficulty concentrating, joint pain, that rash over the bridge of the nose spreading to the cheeks, photosensitivity, oral or nasal ulcers, dry eyes, dry mouth, hypertension, leukopenia, thrombocytopenia, alopecia, chest pain. Some nursing diagnoses for lupus will include fatigue related to chronic inflammation and altered immunity, altered skin integrity related to the rash, altered self-image related to manifestations such as the rash and alopecia. So some nursing interventions for lupus. We are nurses, so we will assess. We will start with vital signs. Hypertension may occur as a renal or cardiac complication. Fever may be present due to infection. Decreased oxygenation saturation may be present because of the complication of interstitial lung disease. Past health history, a head to toe physical assessment. Diagnosis will be based on the presence of 4 of the 17 clinical manifestations in the patient's health and physical assessment. Monitor lab values, BUN and creatinine, urinalysis, CBC, the CRP and the ESR, coagulation studies. Elevated BUN and creatinine and the presence of proteinuria may indicate decreased renal function, decreased white blood cells, platelets, and red blood cells are common and may require intervention. Elevated CRP and or ESR may indicate inflammation and that may require an intervention. Coagulopathies are a complication. So nursing actions, we will administer analgesics and anti-inflammatory medications as ordered. Administer medications as ordered to treat specific clinical manifestations as they occur. Patient education for lupus. The disease process. It is very important for patients to understand the disease process in order to manage the disease and help prevent complications. They need to use a sunscreen daily. They need to be educated about energy conservation and activity prioritization. And they need to keep up to date on immunizations, but there will be no live vaccines for this population. No live vaccines. Avoid oral contraceptives in patients who have migraine headaches, Raynaud's phenomenon, a history of phlebitis, or antiphospholipid antibodies. We can assist in referrals to a pulmonologist, a nephrologist, a neurologist, a cardiologist, and a dermatologist as it is needed. And then how do I know that I've done a good job taking care of this patient with lupus? Medication compliance plays a major role in controlling the disease. Frequent evaluations should be performed on a regular basis by a rheumatologist who monitors disease progression and treats new clinical manifestations as they come up. And patients with well-controlled SLE are high-functioning individuals who can carry out the usual activities of daily living. So, gout, gout, that will affect approximately 2% of people and is most found in men ages 40 to 60 years of age and women aged 55 to 70. Hmm. So, risk factors will include obesity, hypertension, those who eat large amounts of meat and seafood, if they use a thiazide diuretic, or if they consume large quantities of alcohol. So, gout is a disease in which monosodium urate crystals are deposited in joints, bone, and soft tissues, accompanied by inflammation. Hyperuricemia is an elevated uric acid level in the blood that must be present prior to the evolution of gout, but the presence of hyperuricemia does not necessarily mean that my patient has gout. Attacks usually resolve after several days or weeks, if even if it is left untreated. And gout can become a chronic inflammatory destructive arthritis. There are three phases, which are termed acute, intercritical, and chronic. Acute usually involves one joint, and it is characterized by acute onset of pain, redness, and swelling. Intercritical is the asymptomatic period between gout attacks. If left untreated, the attacks may come more often with a shortened intercritical period. Chronic is characterized by repeated attacks in many years, leading to the production of COFI. COFI is uric acid deposits or nodules in the joint and joint destruction. About 80% of patients present with the first attack affecting a lower extremity joint, typically the first metatarsophalangeal joint. Podagra is the term used to identify gout in the first MTP. The severity of the attack typically peaks at 12 to 24 hours after onset. Diagnosis. Presumptive diagnosis may be achieved by combining objective, subjective, and then laboratory data. Definitive diagnosis can be made only by observing crystals in synovial fluid or hypophaseous material. Radiographical evidence is not necessary for diagnosis. Joint erosions and soft tissue nodules are radiographically consistent with chronic gouty arthritis. Other diagnoses, such as septic arthritis, trauma, and pseudogout, need also to be ruled out. The presentation of septic arthritis and pseudogout may mimic acute gout and may not be differentiated by clinical examination alone. So in some cases, it is necessary to examine joint fluid for uric acid crystals to make a definitive diagnosis. So, non-pharmacological therapy of gout will consist of weight management because obesity is a modifiable risk. Alcoholic beverages, specifically beer, should be avoided because they increase uric acid production. Linting of the affected joint may also be useful in protecting the joint and alleviating pain. So, pharmacological therapy will depend on which state the patient is in when they come in requesting treatment. Some common medications will include NSAIDs such as indocin and colchicine, which will decrease the buildup of uric acid crystals in the joint. Glucocorticoids are used to reduce inflammation and provide pain relief. Managing chronic gout will focus on the use of uric acid lowering agents. Uric acid lowering agents such as allopurinol or Uloric may reduce serum uric acid by inhibiting the production of uric acid. One very important fact to remember is that acute gout is never treated in that moment with a uric acid lowering agent, such as allopurinol. So, complications of gout, uric crystals can aggregate to form a stone, making patients more likely to experience a kidney stone. So, nursing management of gout. Clinical manifestations are related to pain and decreased function due to the accumulation of the uric crystals and the tophi nodules in the affected joint. So, the nurse may identify intense joint pain, tenderness on palpation of the affected joint, swelling of the affected joint, redness of the affected joint, warmth over the affected joint, decreased range of motion, and then the presence of. So, some nursing diagnoses for gout: pain related to the disease process, and then knowledge deficit related to the disease process. And so, some nursing interventions for gout. We are going to assess, because we are nurses and that is what we do. We are going to monitor the uric acid level. Hyperuricemia will promote those crystal formations. We will assess for the presence of tophi. Remember, tophi are those lumps or hard nodules under the skin around the joint. The presence of tophi is indicative of advanced gout. Assess for red, swollen, and painful joints. This will indicate an acute gout flare. We will assess their pain level. Some nursing actions for gout. We will administer uric acid lowering agents as directed, administer analgesics and anti-inflammatory medications as ordered, and administer glucocorticoid therapy as directed. So, patient education for gout. Ladies and gentlemen, listen up, and then listen up one more time. This patient needs to avoid alcoholic beverages, especially beer, as this will increase serum uric acid levels. They need to take their uric acid lowering agents as directed. They need to report a flare promptly. They need to be educated about proper nutrition, avoiding high purine foods such as red meat, liver, and fish. So, how do I know that I've done a good job taking care of this patient that has gout? The goal of treatment is to eliminate gout flares and to prevent joint destruction. This is done by controlling the uric acid level. So, a well managed patient will take their gout lowering agent appropriately, avoid those foods that are containing purines, such as seafood and red meat, and they will limit their alcohol consumption. So, I just want to take a few minutes to talk about fibromyalgia. Fibromyalgia is the most common cause of a chronic musculoskeletal pain in women between the ages of 20 and 55. This is commonly found in patients with rheumatic conditions such as RA, SLE, and Sjogren's syndrome. Sjogren's syndrome is an autoimmune disorder that is characterized by dry eyes and a dry mouth. So onset will usually occur in middle adulthood, but it can occur in adolescence, it can occur later in life, it can occur. Genetic factors may play a role in predisposing patients. So, chronic uh, chronic pain disorder of soft connective tissues is fibromyalgia, and this is characterized by widespread pain and other symptoms such as insomnia, fatigue, stiffness, and cognitive dysfunction. Cognitive dysfunction meaning the inability to focus or concentrate on a task. Etiology and pathophysiology are unclear. Some current theories include the abnormal processing of stimuli by the central nervous system, causing normal pain signals that are amplified. So, clinical manifestations, the amplification of stimuli will cause patients to feel pain, whereas those without fibromyalgia would not feel pain. This can be triggered by an infection or physical or an emotional trauma. Normal daily stress combined with common symptoms can create a cycle that will build on one another. So, diagnosis, laboratory testing is not necessary for diagnosis, but it may be necessary to rule out other disease processes. History and physical assessment are used for diagnosis. The ACR criteria for diagnosis will require that the patient experience pain at 11 or more of 18 specified locations, otherwise known as tender points, and have widespread points. The assessment of these tender points is done by applying pressure, and this pressure will be comparable to the pressure to blanch a nail bed to specific points on the body. So, non pharmacological treatment of fibromyalgia will include physical therapy, strength training, aerobic exercise, cognitive behavior therapy, education, and then self management. So, pharmacological therapy for fibromyalgia. This will include medications that will alter chemicals in the brain, such as serotonin and norepinephrine, or block overactivity of the nerve cells. Other medications that may prove useful are those that will improve sleep and treat pain. So, nursing management of fibromyalgia. The nurse may identify the following clinical manifestations in patients due to enhanced pain perception and stress related to enhanced pain. And this is fatigue, arthralgia and myalgia, headache, abdominal pain, a decreased desire to participate in activity, non restorative sleep, and then anxiety. So, some nursing diagnoses for fibromyalgia, chronic pain related to the disease process, ineffective coping skills related to chronic pain, depressed mood related to chronic pain, and then an ineffective sleep pattern related to chronic pain. So, some nursing interventions for fibromyalgia. We are nurses, so we are going to assess. We will look at those vital signs. Pain may alter vital signs. There may be an increased heart rate and an increased blood pressure. We will assess their affect. Depression can be associated with fibromyalgia, and we will assess their pain. Increased levels will indicate ineffective treatment strategies. Some nursing actions for fibromyalgia. We will administer medications as ordered, those nonsteroidal anti-inflammatories, antidepressants, anti-seizure medications. These medications work for this population. We don't know why. We can provide a heating pad for painful muscles and then cold packs for painful joints. So, some patient education for fibromyalgia. The patient needs to take their medications only as prescribed. So, improper use of medications can be very harmful. Participate in regular physical activity, teach effective coping skills, and assist with referring the patient for a sleep study. Ineffective sleep may increase pain and increase their fatigue. We can assist with referring the patient to a mental health provider if that is necessary. We can assist with a referral to occupational and physical therapies as needed. And then, how do I know that I've done a good job taking care of this patient with fibromyalgia? Compliance with a healthy diet and an exercise regimen and getting adequate rest are essential in management. Taking their medications as prescribed will help control the enhanced sensation of pain and the depression that can be associated with the disease. And a well managed patient will have decreased pain and fatigue, a healthy sleep pattern, and maintenance or improvement of strength and function. Ladies and gentlemen, thank you very much for your time and for your attention. I hope this helps. The voiceover helps. And as always, if you think that I can be of help, please reach out with any questions, comments, or concerns. Again, thank you for your time.